Good afternoon, my friend. You are all welcome again to the next ISCH Post-TCT webinar, Post-TCT 2023 summary, part 2 today on cellular therapy. We're going to start with cellular therapy presentation at the TCT meeting. We already reviewed the transplant abstract on March 14th, and that webinar recording is available on ISCH webinar. Again, before I start, I wanted to thank all our friends and well-wishers who provided their presentation material for this webinar. Thank you again, and welcome to this part 2 cellular therapy post-TCT webinar. So this study was presented in the best abstract session. Nice study. As we all know, CD22 is expressed on the majority of B-cell lymphomas. Autologous CAR-T cells targeting CD22 in adult patients with relapsed refractory large B-cell lymphoma, focusing on those with CD19 CAR-T refractory, CAR-19 refractory disease. This is a single institutional phase 1 clinical trial evaluated CAR-22 construct from M971. It's highlighted here. And it is 41BB CD3Z zeta endomains, heavily pretreated patient group. Median of 4 prior line of therapy, 97% progress after prior CAR-19 therapy. 94% patient experience CRS, all mild. 5 patients, 14% experience ICANS. All cases were grade 1 to 2, and it all resolves in 2 days, you can see here. The problem with CD20 CAR is CAR HLH, a syndrome of high ferritin, cytopenia, coagulopathy, liver abnormalities. I don't need to go in detail. It occurred in 33% in patients receiving dose level 2, and 7% in dose level 1. All 5 patients achieved a complete response. Overall response rate and complete response are 72%, you can see here, and CR rate was 53%. Only 1 of 19 patients who achieved CR has a relapse to date. Highly effective and safe data for patients who are refractory after CAR-19 therapy. So we do have an option. So now let's review the next abstract, which was presented in late-breaking abstract number 1. KarMMa-3, phase 3 randomized controlled trial. We presented some of this data in the past. Survival outcomes are poor in patients with relapsed refractory myeloma who are triple class exposed. Triple class meaning commonly used immunomodulatory, protease inhibitor, and nowadays most patients receive anti-CD38 monoclonal antibodies. For example, DARA. So KarMMa-3 is an international open-label randomized controlled trial. Enroll patients with relapsed refractory who receive 2 to 4 prior regimen, including what we discussed, triple refractory. Patients were randomized 2 to 1. You can see here, 2 to 1 to ID-cell or standard care regimen. Investigator choice of like DPD, DVD, IRD, KD, EPD-based prior regimen. Study endpoint listed here, efficacy assessment for ITT, very important. Of 386 patients, you can see here 254 ID-cell, 130 to standard of care, 225 received ID-cell, 126 received standard regimen. Median follow-up, decent. Data cutoff was 18.6 months. Median time since diagnosis, 4.1 years. High risk cytogenicity, you can see here, 44% were all generally balanced group. Median prior therapy, 3. Triple class refractory, 66%. And DARA, previous DARA in almost all patients, 95%, you can see here. ID-cell significantly improved progression-free survival versus standard regimen. You can see here highly significant data. Progression-free survival and overall survival benefit of ide-cel was consistent across multiple patient subgroup highlighted in light green or blue arrow lines. Treatment with ide-cel resulted in a significantly higher overall response rate, with more patients achieving CR or better and MRD negative status. You can see nicely here. Inherent to CAR-T biology, there was a considerable interpatient variability. You can see dancing graph here in cell expansion, and the lowest quartile of expansion was present across all actual dose levels. Higher quartiles of pre-ide-cel expansion measured by PK exposure, AUC 28 days, were associated with longer progression-free survival. You can see top blue line. In the treated population, a grade 3 to 4 adverse events occurred in majority of patients, 93 almost in ide-cel versus 75 in standard regimen arm. And grade 5 adverse event was about 14%, 15% in ide-cel, and 6% in standard of care arm. Toxicity profile of ide-cel was consistent with previous studies. Low incidence of grade 3 CRS, grade 2 or higher CRS, and neurotoxicity consistent with previous report, and resolved within median of 2 to 3 days. No Parkinsonism was reported, and I'm sure why I mentioned this here. ide-cel demonstrated clinically meaningful improvement on patient-reported outcome, including symptom, functioning, quality of life versus standard regimen. So this is the conclusion side. Author concluded that ide-cel treatment result in a significant improvement in progression-free survival, overall response rate, with deeper and more durable response versus standard regimen. ide-cel benefit was consistent across different difficult to treat subgroup. Toxicity profile of ide-cel was manageable and consistent with prior study. This was another late-breaking abstract. Number 4, T-cell has proven effective at achieving more than 80% complete response rate in children and young adults with ALL, yet treatment options are limited for patients who do not respond or who relapse after T-cell. Second, CAR-T infusion have been used. We have using some standard of care. However, there is a limited data on patients treated with CAR-T reinfusion following commercial T-cell. Author conducted a retrospective study in nice children and young adults with B-cell ALL who received T-cell infusion following commercial CAR-T. Across 15 pediatric real-world CAR consortium and a low CAR consortium in adults, lymphoma, ALL, myeloma, because we get lots of good data. Collected data on 43 patients. Most 28 patients were reinfused per standard of care, while 15 were treated as SINDs. Median time for first to second infusion was about 6 months. Indication for reinfusion were majority B-cell antigen loss, while in ongoing CR, 26 patients. Disease recurrence in 15 and unknown in 1 patient. Increased lymphodepletion was used with reinfusion in quarter of patient, 8 out of 43 patients. Cytoxan was slightly increased dose to 900 to 15 milligram per meter square for 2 days. T-cell reinfusion was very well tolerated. So look at the result. Among 16 patients treated with CAR infusion due to disease, no response or recurrence. That's what my area of interest was. 50% achieved morphological CR. Some MRD negative, some MRD positive. All MRD positive, even after second infusion, developed fulminant relapse. Of 26 patients reinfused for BCI loss, 5 had a detective disease at day 28. So of remaining 21, if we take out 5 out of 26, 21, meaning 33% who maintained their CR status successfully reestablished BCA, B cell antigen at day 2. So after T cell infusion, 63% patients ultimately underwent transplantation. Of those who underwent transplantation, out of 27 patients, 13, meaning 48% patients received CAR-T infusion for BCL loss, and almost half, 48%, received due to disease progression or recurrence. 17 patients, 63%, who underwent transplant were alive at the time of last follow-up. You can see here, following T cell reinfusion, 1 year overall survival and event-free survival is listed here. So in conclusion, what I can say again is, second infusion is tolerated. We know that. We can successfully achieve a CR or reestablish BCN in some patients, B cell antigen, but the outcome is still not good. The remission duration are brief in most, and BCA duration is also limited. We need to find something better. TAB cell in PTLD. I think we reviewed last month also this abstract during post-ASH webinar, and we also reviewed last year. Now, with original presentation and material and longer follow-up, the relapsed refractory EBV positive EPLD, PTLD, ultra rare disease, we have seen very rarely, but poor outcome, very poor outcome, and no approved PTLD therapy. We use rituximab plus or minus chemotherapy. TAB cell is an off-the-shelf allogeneic EBV specific T cell immunotherapy. It is being studied in EBV positive PTLD, which you can see here. TAB cell has demonstrated an objective response rate cited here of more than 50% and more than 80% 2-year overall survival in responders. I'm sure you are aware about this JCI paper published in 2020. Safety data in more than 180 patients showed tumor fled at the only and controllable, only identifiable risk. Authors have previously presented data from the first phase 3 multi-center open-label global study of TAB cell in EBV positive PTLD post-transplant, post-liquid transplant, and post-solid organ transplant, where rituximab with or without chemotherapy failed. Study name, ALLELE. Here, author reported updated outcome, more patient, longer follow-up from ALLELE study. Patient received TAB cell on day 1, 8, 15, in a 35 days cycle. 43 patients received more than or equal to 1 TAB cell dose, median of 2 cycles. As you remember, 35 day cycle, median 2 cycles ranges from 1 to 6. You can see here, 67% of patients had diffuse large B-cell lymphoma, 77% had an extranodal disease. Overall response rate, 50%. In transplantation, 52%, solid organ transplant, median time to response was fast, 1 month. We had one patient, I remember, responded fast. 12 of 22 patients responded had durable response of more than 6 months, and median duration of response was almost 2 years. Response were similar among subgroup. You can see here for your later review. More information for your later review. In short, 1 year overall survival was 61%, 70% for liquid transplant, 56% for solid organ transplant. As expected, patients responding to TAB cell, higher 1 year overall survival, 85% versus 35% among non-responder. Again, data confirms that TAB cell provide consistent, clinically meaningful outcome and no safety concern. Again, this abstract was also presented at the ASH and was reviewed last month during our ISCH post-ASH webinar. This time I have original presentation material. And let me mention, I love this abstract. As we all know, patients with renal insufficiency were excluded from the registration clinical trial. This is a reality. Renal insufficiency impacts a clinically significant proportion of patients with multiple myeloma, and safety and efficacy profile of CAR-T remain unknown in this population. So author evaluated real-world outcome of patients with renal insufficiency treated with standard of care ide-cel. Of 211 ide-cel data, 11 centers, 13% had renal insufficiency. Out of this, 39% of this had severe renal insufficiency or on dialysis, meaning creatinine clearance less than 30. A renal insufficiency group had more older patients, more prior line of therapy. Follow-up, fludarabine dose was adjusted in majority of patients, more than 80%, based on, as we know, protocol A, and our pharmacies are on top of everything on dose adjustment of conditioning regimen. Only issue was renal insufficiency group had a longer hospital stay and were more likely to experience short-term high-grade cytopenia, which you can see here. No worsening in renal function, that's what first question comes into the mind after CAR-T, but improvement in some noted. Among 10 patients with creatinine clearance less than 30, 3 experienced improvement in creatinine clearance to 30 to 49, 30 to 50, while 7 patients remained similar creatinine clearance at day 30. Efficacy, nice data. Renal insufficiency had overall response rate, 96% versus 83%. You can see the CR and VGPR rate here. On multivariate analysis, renal insufficiency was not an independent factor for progression-free survival. So author summarized that treatment with ide-cel is feasible in relapsed refractory multiple myeloma with renal insufficiency with a comparable efficacy profile as patient without renal insufficiency. Safety was comparable with notable exception of high prevalence of short-term high-grade cytopenia and prolonged hospitalization. In transplant field, we used to believe that past patient history of limited chronic GVHD gives better graft versus leukemia effect in the previous study. Same here. To whether CRS, patients developing mild, moderate CRS, can give us better disease control. And that's what this abstract answer our question, whether CRS drives CRS versus lymphoma effect or not. 8 academic medical centers participated in this study, United States. All had an option to prescribe either axi-cel or tisa-cel. About 350 patients underwent pheresis, 200 received axi-cel, and about 100 patients received tisa-cel. 75% patients developed CRS. Now, cutting short here, let me tell you the summary. No difference in progression-free survival, overall survival between the group, and confirmed in multivariate analysis. In an exploratory analysis, grade of CRS, whether grade 1, 2, 3, 4, higher, did not influence progression-free survival or overall survival. This finding support the conclusion that development of CRS does not impact efficacy of CAR-T therapy. So FDA-approved CAR therapy are commonly administered in this setting. Many centers have reported on safety and feasibility of hospital-based outpatient practice. Author reported in their experience, this is a Mayo Clinic study, the feasibility and safety of hospital-based outpatient, infusion-based, you have to have infusion room, HPO, management of patients receiving CAR-T. In their experience, use of bridging therapy, in this past experience, bridging therapy, elevated CRP, and elevated LDH are predictor of early hospital admission within 3 days post-transplant, post-CAR-T with aggressive lymphoma. Patient developed this fact factor. Model was developed on hospital-based outpatient therapy. And we are also one of the predominantly outpatient CAR-T therapy for lymphomas in our program at Vanderbilt. So this is the conclusions I just want to share with you. They applied the previous model, use of bridging therapy, elevated CRP, elevated LDH, to current cohort of 50 patients and found this to remain correlated with early hospital admission. All patients with this criteria required admission. The expanded study confirmed that hospital-based outpatient treatment is feasible, and approximately 20% of the patients require no admission, means they never admitted to the hospital for CAR-T therapy for 30 days. Bendamustine lymphodepletion prior to CAR-T therapy. This reminds us about our fludarabine shortest timing. Chemotherapy with lymphodepletion with fludarabine considered as a standard of lymphodepleting regimen for CAR-T therapy. The national shortage of fludarabine urged the need for alternate lymphodepletion chemotherapy. So Benda is a purine analog alkylating that has been used as a lymphodepleting agent for T-cell, and I'm sure publication last year from my friend from WashU, Dr. Gilardi. There are no data for Benda lymphodepletion other than CAR product for relapsed refractory non-Hodgkin's lymphoma. So in this study, authors sought to analyze CAR-T expansion, CAR-T toxicity, and clinical outcome for patients receiving CAR therapy with Benda as a lymphodepleting agent. They use 90 milligram per meter square, day -4 and day 3. Patient characteristics reviewed here. Fludarabine caused deeper lymphopenia compared to bendamustine. Nice graph. Less neutropenia with Benda in first month post-axicel. Similar rate of scar, CRS, and icons between Benda and fludarabine lymphodepleting regimen. Similar CAR expansion in first month post-CAR-T axicel infusion. So in summary, author concluded that there are a lot of the data also, but clinical data, relevant clinical practice data. Benda is a safe and result in a significant CAR expansion with no undesired neutropenia for CAR-T therapy. This is one of my favorite abstracts. You can see a big smile on my face. Many patients develop recurrence after transplantation. Based on preclinical data, studies provided that rationally to test interferon, gamma interferon with DLI as a treatment for the relapse AML and MDS, where we need more progress. We're still not good at managing early relapse post-transplantation in myeloid malignancy. This is an IIT phase 2 trial aimed to evaluate, number one, safety of gamma interferon and DLI for treating post-transplant relapses. Number two, biological effect of gamma interferon on myeloblast in vivo. And I'm going to skip that because that's not my area of expertise. I'm not a translational scientist, but I'm going to review mainly clinical part of the study. Gamma interferon, they use this Horizon therapeutic product, Actimmune, was given as a monotherapy for 4 weeks, followed by DLI and 4 gamma interferon for up to 8 additional weeks. Clinical response were evaluated at 4, 12, 24 weeks after first dose of gamma interferon. Nice schema here. Markers they analyzed were HLA, ICAM1, PDL1 expression were measured on bone marrow leukemic blast by flow cytometry before and after gamma interferon. Key eligibility criteria, including patient receiving interferon and DLI on low dose immunosuppression, which include, if you're a low dose immunosuppression patient, you can still do this interferon and DLI. Very interesting to me. Only 4 patients, but provide us lots of founding information. I said set for larger study. These are the characteristics of 4 patients. So all 4 patients tolerated gamma interferon well as a monotherapy post-transplant and in combination with DLI, with flu-like symptoms and cytopenia as the most common AEs. Grade 3 or higher adverse events were febrile neutropenia in 1 patient out of 4 and reversible encephalopathy in 1 out of 4 patients, which we need to keep in mind. 3 patients who received DLI and gamma interferon achieved complete molecular and cytogenetic response. You can see nice figure here, with conversion to full dome chimerism coincident with steroid-sensitive GVHD. All remain in complete remission without additional anti-leukemia therapy. So this is the first study to show safety and tolerability of gamma interferon in allotransplant recipient. Continuing to enroll patients in a phase 1 trial with short-term gamma interferon monotherapy. Nice application. This was presented at the ASH in Orlando also last month. I'm going to briefly review, and this is my slide from the last ASH review. Similar data, so I'm reusing the same slide. Allotransplant recipient, it is very well known that are highly susceptible to reactivation of double-stranded DNA virus. Approximately 70% of high-risk allotransplant recipients develop clinically significant infection. Author presented result from phase 2 trial evaluating safety and efficacy of posoleucel, a partially HLA-matched off-the-shelf multivirus-specific T-cell investigational product for preventing clinically significant, commonly seen 6 viruses listed here. High-risk allotransplant recipient defined as, again highlighted here, graft from haplo, cord blood, mismatch unrelated, match unrelated with lymphocyte count less than 180, as well as recipient who underwent T-cell depletion in vivo ex vivo. To be eligible, patient had to be engrafted and within 15 to 450 days post-transplant. The patient received up to 7 infusions of posoleucel once every 14 days. And this is very interesting data. Data showed 8 patients, 31% had acute GVHD, 2 to 4. Not surprising considering these are all high-risk allotransplant patients to develop GVHD. Patient who received posoleucel had a lower than expected rate of clinically significant viral infection from 6 targeted viruses, despite the observed and expected low-level viral reactivation seen throughout the study. A repeat dosing of posoleucel was safe and well tolerated. Posoleucel VSTs were detected in vivo up to 26 weeks, and reconstituting T-cell demonstrated functional specificity for multiple viruses. Placebo-controlled phase 3 trial is ongoing, and I thank you very much. This concludes part 2 cellular therapy of our TCT Post-TCT 2023 ISCH webinar. Again, thank you very much. If you are not able to attend in-person webinar, a live webinar, ISCH webinar, post-Congress webinar, always available on ISCH website. Thank you again for your attention.